All right, I have that it is the top of the hour, so I'm going to start us off. So I'm Louise Walter. I'm chief of the UCSF Division of Geriatrics, and I'm happy to welcome everybody to our first Geriatrics and Palliative Care Grand Rounds of the new academic year. So this is exciting. A few quick reminders before we get started. The meeting is being recorded, and as an audience member, your microphones are muted. So if you want to ask a question, please use the Q&A. Put your questions in the Q&A section since we've disabled the chat function, and we will address questions at the end. So today I'm delighted to introduce our Grand Round speaker, Dr. Anna Chodos. Dr. Chodos is an assistant professor of medicine who joined the UCSF faculty in 2014. Before that, Dr. Chodos completed medical school at Harvard, an internal medicine residency at UCSF, and a geriatric medicine fellowship at UCSF. Dr. Chodos is nationally known for her contributions to improve the care of vulnerable elders in the safety net and primary care settings. She's a leader in the UCSF Geriatric Workforce Enhancement Program, which is a large HRSA-funded program that's about geriatricizing primary care across the Bay Area. And she's also been leading efforts to develop and implement innovative outpatient geriatric programs at the Zuckerberg San Francisco General. She's currently the director of whole person geriatrics for the San Francisco Health Network and is working with the San Francisco Department of Public Health to help nursing homes and residential care facilities respond effectively to the COVID-19 pandemic. Her talk today is titled Our Crisis, Geriatrics in the Public Health Response in Nursing Homes and Residential Care Settings during COVID-19. So thank you so much, Anna.
Thank you, Louise. Can you hear me okay? Oops. Okay. I have purposefully minimized everyone, so if there's a problem, someone might have to actually just drive over here and tell me. I'm at the General at the moment in my office, if that's not obvious. Anyway, I'm extremely grateful for this opportunity. And thank you so much for having me. This is not something I anticipated presenting on when I was actually invited to speak as a Grand Round speaker, but I'm just so grateful for the opportunity to do so. I really hope you learned something and you enjoy the talk. And unfortunately, I'm so sorry that I can't interact with you more than in this format. I really look forward to your questions at the end. At the moment, the reason I'm presenting on this topic is because among my many roles, I somewhat volunteered for the role as the medical lead in the skilled nursing home outbreak team as part of our San Francisco COVID Command Center response, which is an integrated response across the city of many city departments, including the Department of Public Health. So in my role as geriatrics in outpatient medicine over at the San Francisco General, which is part of our affiliation agreement with UCSF, I had this amazing opportunity to also see how I could help out with our city's response to COVID. So I have no disclosures to make, and broadly the outline for my talk this afternoon will be to touch on the epidemiology of COVID in congregate settings for older adults. Then I'm going to talk about what the public health response to this threat of COVID in congregate settings has looked like. And then our role as geriatricians, how the heck did I end up here kind of thing in the response as well. And really looking forward to your thoughts. First, a little bit of context. Again, why am I talking about this and sort of how did I end up here? Luckily, it's easy to start at the very beginning. So COVID actually in the United States is a story in part of COVID in skilled nursing facilities and other congregate settings for older adults. In fact, the first time this really hit reality for the US that COVID was here and being spread in the community was a huge outbreak at what was called the Life Care Center of Kirkland in Washington. So Kirkland realized that it had a COVID outbreak on February 28th, 2020, when they got finally some COVID results back on some of their hospitalized. It was connected potentially to early transmission of the virus in Washington state. So the first case that we knew about at the time was January 21st with a traveler from Wuhan. And then this outbreak several weeks later started. And in fact, it was also closely tied with the first known death at the time, which happened the very next morning on February 29th at 9:30 in the morning. And so as an effort for you, in case you get pulled away or aren't able to sit through the whole talk, I think there are a lot of lessons learned. In fact, most of the lessons learned that you'll see throughout the rest of the talk in this one outbreak. So by the time it was over, we learned a lot of things that were later reinforced by more outbreaks that we've seen. So first of all, its regulator was involved, its regulatory agencies, so the Centers for Medicaid Services, and because of 3 of the most serious violations, immediate jeopardy violations in that facility, they levied $600,000 in fines. The CDC was involved and also found many things that we've seen as contributing to outbreaks in other places as well in the United States, but principally that staff were working while symptomatic and in more than one facility, that they really didn't know how to use PPE and weren't adhering to its use routinely, and that they didn't have enough of PPE or even sanitizer, and that in general, they were kind of caught unawares. They weren't really thinking about COVID, and then even if they were, they didn't have the testing capacity in their area to really confirm that and address it. It also showed how serious this was. So they had 52 total deaths by the time all was said and done, 39 of those in residents, and across their facility, they had 108 residents at the time. Almost all were infected, and of those, it roughly comes out to about a 39% mortality out of those that were infected. So this outbreak was, again, really put this issue on the map, and it put it on the map really early. And the press really helped to reinforce how serious an issue this was. And I don't know about you, but for me, honestly, the lay press has been just as great a source of information as emails from our colleagues and experts at UCSF Infectious Disease and the CDC and other journals like Journal of American Geriatrics. But in this case, the things that the press, excuse me, my apologies. The things that the press were emphasizing were really the headline issues, that it's not clear what was going on with the response in the facility, like they were struggling, and that it was a hugely morbid and risky virus for people in these settings. So 35 deaths, and it appears that the risk in the elder care facilities is real and it's here. But then there were other issues that came up that really interested me as well and really piqued my interest in this area. And that's things like, this came out a little bit later, but just the fact that not so much the landlocked cruise ships part of this quote, but a blog about the gentleman who runs this chain. So the Life Care Centers of America are the biggest privately owned chain of nursing homes. So interesting that this is where we had our first known major outbreak in the country. And it's the only chain that has minted a billionaire. I'm sure others have minted many millionaires, but it's an interesting aspect of this whole phenomenon that nursing homes can be a very profitable industry for people. And then the other thing that was coming out clearly and pretty early on, and particularly with Kirkland, were pictures of separated family members, the challenges that people were having with getting information about their loved ones, so communication issues from facilities and local authorities, and then also just the human toll, right? Not just an issue of mortality, morbidity, but the lived lives of people living there and their family. So for example, this woman was admitted 3 days before the outbreak started, and then her daughter said basically after that, once their doors closed because of the outbreak, she was essentially a prisoner in the facility, was how she phrased it. She couldn't get through. Her mother was at that time positive for COVID. One thing we haven't heard a lot about, but I have found some information, is the facility's perspective on this. So the Kirkland, again, the hottest outbreak there really was, the one with the most attention on it in this country, and the first. So they were potentially unlucky in some respects in that regard. But they have a really interesting blog and a really interesting website, and they have a lot of tributes to their lost residents and staff members, which I encourage you to watch if you have nothing else to do. But basically, they frame what happened to them as something that happened to them in really colorful language. So the Kirkland story is not a story about a skilled nursing facility that did everything wrong. It's a story about a dedicated group of people who found themselves trapped in a bunker with the eyes of the world suddenly on them as the clock struck midnight on February 29, 2020. It's the story of a passionate staff of caregivers who banded together and did things right. Of course, I think obviously CMS didn't totally agree with that view of things, but it was certainly something that took a human toll in another way on the people of that facility and the staff and caregivers. So where did, of course, all this was going on. I know many of us saw it and were aware of it and were horrified. But I think for me as well, especially as life really was changing and it didn't feel like business as usual, other news was coming out that I think motivated me even more to try to find a way to help. And that was in part things that really troubling characterization, nursing homes being death pits. Is this really the reality or is this hyperbole? What's really going on here? And then things that I think speak to all of us, like this characterization of the nursing homes really experiencing this horror, obviously very in keeping with the term death pit, but really because of this issue of decades of mistreatment. I mean, this is what happens when vulnerable people are exposed to something to which they are really susceptible. The other aspect here is, of course, ageism, and I really credit our colleague, Louise Aronson, with bringing attention to this issue as well, and how not only mistreatment, but actually structural and pervasive ageism helped make this pandemic really worse. So just to say that, I think I really had to question, what can I do? Unfortunately, in a time of everything being in upheaval, and being affiliated with the local Department of Public Health, there were some opportunities. And I've had this opportunity to go from helping with the community mitigation response, which is one part of how our city has organized their response, to create a community education and outreach branch. So working with the senior group on that, and proceeding to work with other individuals in our division who have played a huge role as well, like Louise Aronson, Meredith Green, and Edgar Pierluisi, and other colleagues like Jeff Newman. But also then moving over to the Outbreak side, when the SNF medical lead went off to be deactivated and returned to her job in another part of the DPH. So I'll explain more about some of the things that I've been able to do after I can explain a little bit about the background of SNFs and the COVID pandemic as they've sort of interacted with one another. So I want us to all be on the same page. So just understanding, I know most of us know this. In fact, most of you know far better than me what is really a skilled nursing facility, how that works, or a residential care facility for the elderly, but just wanted to establish some terms that these are really the congregate settings I'm talking about. There are some residential care settings where adults live, adults with frailty, comorbidities, chronic conditions as well, that are differently licensed and called different things like adult residential facilities that we'll talk about as well, and are sort of lumped in with, certainly with the response and the approach to supporting and helping these places manage COVID risk. But just really quick, when we're thinking about these places, like what are we thinking about? What are these places, right? What is this ecosystem? Of course, it's the residents, and that's been a huge focus. These are the highest risks for morbidity, mortality, but also staff, right? Tons of staff. In fact, more staff than residents, usually. So a skilled nursing facility, of course, in the title, is gonna have nurses, and it's gonna be different levels of licensure. They're also gonna have a mandated infection control preventionist, although pre-COVID, that was not necessarily a full-time role. It's gonna be a ton of caregivers, like certified nursing assistants, or even just people hired to do care, potentially. If it's in a residential care facility, they may not have any particular license or credential. And then a ton of other staff, clinical, rehab, nutrition, for example, but also ancillary staff, janitorial, laundry, administrative, right? So when you're thinking about mitigating risk, among whom and how is actually really critical. And then, at least once upon a time, there were a lot of visitors. There was a lot of in and out. And of course, there's other types of things like regulators going in or ombuds people going in, things like that. And then when we think about these two settings, why is there this vulnerability, piled on top of other social determinants of health? We know that there's intrinsic factors. So certainly, undoubtedly, we've seen globally that older age and, with every decade goes a higher risk of a vulnerability to severe COVID illness. Same goes for multimorbidity. And certainly that is concentrated within people living within these congregate settings. But the other thing is just so clearly environmental. So one part that I think always seems to get lost, particularly in the public press version of what's happening, is like, obviously they're older, they're frailer, that's why they're dying from COVID. But clearly their risk of exposure and their risk of high levels of exposure is so much higher. They're living in small rooms with lots of people. The very fact that they're there means they have a functional disability. That means they need some hands-on care. And then their care providers are typically not dedicated only to them and have to see many other people. So there's a lot of environmental and structural reasons why they're going to be higher risk. And then the other thing we know about these places, and this is just, a pretty colored map to demonstrate one principle, which is there's so much variation in these places across the country and even within our own city. So the type, the quality, how they're organized, how they're doing in terms of infection control, staffing, all of those things. And this particular map just shows the variability in from a annual survey and how they do in terms of substandard quality of care measures, and dark blue being the worst, white being the best. And we can see that California is sitting right in the middle, and from 2015 anyway. And then also, how many people are we talking about here? So at any given time, about 1.4 million people live in skilled nursing. So I don't have the same data for residential care facilities for the elderly. But in California, that's 100,000 people at any given time. But also we know there's a lot of churn, and that ends up being about 400,000 people per year. If you just think about it though, in terms of the overall population and how oversized the issue of COVID in these facilities has been, these are, in both of these cases, this is far less than 1% of the entire population of the country or the state at any given time is in a skilled nursing facility. And I'm sorry, I can't recall, so I just want to make sure that everybody is clear. If I say residential care facility of the elderly, in the standard media parlance, if you will, it's usually assisted living or something like that. And a skilled nursing facility will be called a nursing home, for example. So lots of different terminology, but that's what I'm talking about. Okay, so what do we know about when COVID comes to the SNF or a congregate setting? How serious is it? Well, right now, and I use the New York Times tracker because it actually aggregates a lot of data that's more useful than some of the more narrow focused ones like the CMS tracker, for example. But basically 40% of all US deaths are affiliated with a facility. So maybe employees, maybe residents. So in a sense, maybe total toll. And also incorporates where available for each state, assisted living data and SNF data. So anyway, they've had it at about 41 to 40% basically this entire time. And they point out that there's huge variability across states. So specifically for California, it was 37% in the most recent numbers that they put up. And in about 18 states, it's over half of deaths are concentrated and with some sort of affiliation with a nursing home. And yes, the majority of those are certainly residents. In California, if we look just at SNF residents, 29% of all of our deaths so far have been in SNF residents. Remember, this is far fewer than their proportion of cases, and way higher than their proportion of population, for sure. So then what do we know about why a particular SNF might be at risk for a COVID case? So an analysis that was senior authored by David Grabowski, which I mentioned because he's on the news all the time, and the first author, Hannah Abrams, they published an analysis up to some data from May about 2,900 facilities, among whom about a third had a case. And for those that had a case, the things that they saw that were associated with that was a larger facility size, kind of makes sense, more people, more risk, Urban location, again, more people, higher density of infection, more risk. The state, because of course prevalence has varied massively by states, along with the, by time certainly. So by the time they did their analysis, some states had much higher prevalence than others. Non-chain status, so we might think, okay, maybe that's because they don't have as many resources. You certainly see the non-chains struggling to get things like PPE or infection control assistance. And then very troubling, of course, in speaking to the intersectionality of various vulnerabilities, is that they found that a greater percentage of African-American residents was associated with a greater risk of having a case. And, but not associated with increased risk of case was, interestingly, their CMS rating on a 5-star scale. So this is what people look at when they want to know, hey, what's a good facility for my family member or loved one? Having had a prior infection violation, Medicaid dependency, although hard to tell if that's really significant because many people end up on Medicaid, just so many people who are living in skilled nursing facilities that are on Medicaid, and ownership was not significantly related, meaning private or for-profit or not-for-profit. But then when they looked at how big were these outbreaks, some places had 1 case, some cases, and these were all residents, by the way, all cases were in residents. A resident case might have had 1, some might have had 50. Outbreak size was associated with facility size, again, possibly a lot more people to have a bigger outbreak. For-profit status was significant here, and again, state probably having to do with, again, these really different prevalences. We also know there's incredible data, 2 great studies, one from California by Charlene Harrington, one in Connecticut by Yu Lee, that showed that nursing staffing ratios, which long associated with quality, infection control violations, things like that, are also associated with COVID risk. So those that had under the recommended minimum of RN staffing had 2 times the risk. And those, they usually think about nursing staffing in a per resident per day amount. That's how it's established as a minimum standard by the states usually. But every 20 minutes more of a nurse per resident day was associated with 22% fewer confirmed cases. So nursing ratios matter. And in these studies, actually, they found that the CMS quality rating did matter, and that more minority residents meant more cases. So again, an unfortunate and another signal that other vulnerabilities account here too. And then what do we know about how mortal COVID is for the residents? Again, we saw that maybe 30 to 40% of cases total out of a population, out of all the cases, have been in nursing home residents. But in Kirkland, remember, it's like 39% mortality. Here it was 29% in a small, relatively small outbreak in Illinois. I mean, 35 residents is a lot of outbreaks. So they had total 126 residents, 35 of whom were positive. And this was also in March, or so relatively early in the pandemic. And at that time, there was 29% mortality. 10 of those folks died. So mortality is high. We also know that asymptomatic folks are really, really common among residents and healthcare workers. So one outbreak in LA where 19 people were positive out of 99, and a third of those were asymptomatic the entire time among the residents. And they had a low death rate up to the point where they reported this data. And then actually here in San Francisco, Dr. Janice Louie, who I took over her position on the Med Epi lead for the SNF team, she looked at how many people were asymptomatic when very early on they did mass testing in a couple of the outbreaks they had in SNFs and one assisted living. And they, depending on the site, a lot of the healthcare workers and a lot of the residents were asymptomatic as well. So again, this is a big feature of these outbreaks. That testing is really important because symptoms are useful, but unfortunately not as useful as we'd like. And of course, you plural, we all know that even though there isn't as great data, and it's a little bit more heterogeneous among the assisted living / RCFE category of sites, clearly there's a high risk. And we need to be thinking about this. And these authors, including Dr. Grabowski, really put that out there early on. So this was in March. And we just don't have that great data. There was one small study published of an outbreak that showed that they had a 70% positivity rate among their residents, and about a third of those did need hospitalization, and only 50% had any symptoms. So again, potentially very morbid in this population as well. And this is somewhat intuitive, right? Why would you think that assisted living is totally different? Of course you wouldn't. It's fair to think maybe that those folks are a little more independent, a little less at risk, but clearly there's so many similarities to nursing home environments, congregate living. Many are older adults with chronic conditions who could, based on functional status, totally qualify for a SNF. That's just not where they happen to live right now. And that need for functional support is going to require interaction with more humans, more staff. But the thing about the environment and the public health response is very different, because there often is no clinical staff whatsoever, no infection control person or infection preventionist on staff. They're regulated by different agencies and just differently. Huge variability in the city. We have many that are 2 to 6 people and a few that are 100 plus. Some very different structurally. So some are far more like apartments, some are like SROs, and much less likely to have familiarity or any PPE, particularly when this all started. So we know that unfortunately these settings, there's less research, less public and policy discussion about them. It appears fewer fatalities, I guess. There's just less data, but many counties are including them either part and parcel with the skilled nursing facility responses and strategies that they're coming up with. That was somewhat true of San Mateo, where they just sort of lumped them all together, particularly around testing strategies that they rolled out. But everywhere is sort of treating them differently. Okay, so now let's get to the part where I tell you a little bit about what the public health responses looked like and some of the principles behind it. And I think we know that the local and state health departments have played a huge role in this pandemic. And I remember, my family telling me when I was a little child not to forget that all global pandemics are local, of course. It's a well-known saying, but there has been so much involvement and so much local variation between states, counties, you name it. So here, the CDPH, our state Department of Public Health, licenses and regulates our SNFs. CMS, Centers for Medicaid and Medicare Services, also does so. So those are two influences on the SNFs, but for the RCFEs, they're licensed differently by the California Department of Social Services. So that's a consideration in terms of how regulations, advice, resources all play out on the ground. And then of course, the real rubber meeting the road is our local health department, our San Francisco Department of Public Health, and now the coordinated command response. And of course, their primary goal in this is to interfere with communicable disease and protect the residents. And that includes things like doing all the work behind tracking the cases, setting up the testing, creating the contact tracing infrastructure, creating local resources for everyone around testing and PPE, and then setting the relevant local policy to our local conditions, including issuing health orders to do that. So what is our local environment? What are we talking about here in San Francisco? So we have 21 skilled nursing facilities. This includes Laguna Honda, which is a city unto itself. That's the old Laguna Honda, now administrative buildings. Right now they have about 720 residents. They usually have, they have capacity for almost 800. We know we have a VA facility here, belovedly run by many of you, and Michi, who I know just left that position, but an incredible place, but also has that support of a federal regulatory agency. Total over the city, there's about room for 2,500 residents and roughly 4,500 staff across all these sites to think about in this response. The other is our residential care facilities for the elderly, which are sort of lumped in this response as a group with other facilities like adult residential and residential care facilities for the chronically ill. The adult residential sites being somewhat more tilted towards those adults with serious mental illness and their needs, and the residential care facilities for the chronically ill, of which there are 5, being a feature of the infrastructure to support people living with HIV/AIDS, and in which there are many older people of age there in place. So total capacity is about 3,500 total for people living in these types of facilities, but right now they're about 2,000 people actually living there. And then there's about 1,900 staff supporting all these different places. And just to note that these numbers include what are called continuing care facilities. So those places that have it all, they have an independent living, RCFE, skilled nursing facility, and people can kind of stay there and age in place. So that's our context for what our facilities are. I just want to point out that we also know that community spread is clearly linked to congregate spread. So California, I guess if you don't mind, just focus on this denser part of the graph. This is data from our state about average 7-day infections. And just to point out, the gray is in the community and the orange is in skilled nursing facilities. That's cases, the rolling 7-day average. And this is deaths in SNFs. So deaths follow number of cases, yes, but also just a clear similarity in shape and number of cases proportional to what's going on in the community. So we know that community affects congregate living in that way. But overall, actually, we're pretty lucky in San Francisco. We have a tremendously lower death rate than other major cities. So this was a story in the SF Gate just yesterday that referenced some data that they shared from the leadership in the command center, that we've had 9.7 deaths per 100,000, which is death per case is 0.87%, which is so much lower than these other areas. Of course, these cities are all massive and we're a much smaller city, but, and this may have somewhat to do with luck or size or something like that. There was also clear early action on the part of our city to implement public health measures. So specifically around these congregate living settings and SNFs, I actually had not appreciated, because being very self-involved that I am, I was remembering the date that we all went into shelter in place, March 16th. But they actually implemented visitor restrictions, a blunt tool, but one to try to influence the spread of COVID in this highly vulnerable population in March 7th. So they shut off visitors to Laguna Honda, then the 10th to all other SNFs, and then March 18th to our RCFEs. So they acted early and somewhat more decisively than other areas perhaps. And then how have we done overall? I don't know how often you guys peruse the SF data dashboard. I spend a lot of time looking at it. And we have had about 11,000 cases total, and 14% of those cases have been in people 60 and older, only 3% 81 and older. But out of deaths, this is the standard curve in a lot of places, that as age goes up, so does COVID mortality. And the deaths are clearly concentrated in people 60 and older, so total 85 deaths in that group. And then among those 81 and over, 52% of deaths. So overall, lucky that we've only had, it's possible at this point we're at 100 deaths as of today, but, or even more. But just to point out that we have had it relatively good compared to other counties and cities. So knowing that that's our context, this is the world we're living in, what is the framework for which we can think about the public health response for these facilities? And there's one framework that I like that was mentioned to me by one of the people who developed it, Dr. Mike Wasserman, who's at the California Association of Long-Term Care Medicine. And in April 2020, they came out with their Quadruple aim for COVID response for congregate facilities. And I like it because it's far simpler than anything you'll see in California Department of Public Health guidance, or even our guidance, which just lists reams and reams of measures to take. The basic principles here, and I think we've all kind of understood that these are the ones that need to be in place, except for maybe fourth, but basically infection control, including a full-time infection preventionist at a SNF, so not the current standard of much lower than that typically. Access to sufficient PPE, obviously to protect and prevent transmission, readily available testing and universal surveillance testing of staff. And then this idea that actually, so they're trying to guide long-term care facilities. They think these places need an emergency response plan and need to be in incident command mode at all times. I really think about that as they're trying to point out that leadership is super important during these times. And what does that actually look like on the ground? So for infection control, for all these facilities, we've had site visits by the state, by our nurses, for outbreak nurses for the SNFs, and then community mitigation branch education group for the RCFEs. The state has a healthcare associated infection program, which has been incredibly involved all over the state. They start out with 8 people for the whole state in that program that could do site visits, and they've ramped up considerably. And then the state required mitigation plans of everyone, of all facilities, excuse me, and just wanted to point out that among all those, many of those were clearly geared towards infection control. So actually mandated full-time infection preventionists, which I haven't necessarily seen at all the sites, training for everyone, testing and cohorting. So that's an infection control strategy. PPE supply, have a plan for that. And they've introduced this model of having red, yellow, green zones when you have a case. So COVID cases in the red. This is my connection's unstable, I'm sorry. Exposed in the yellow and then not exposed in the green. And those are completely separate. You really go for completely walled off areas in terms of staff and environmental exposure. The second one, PPE, just to point out, our city has had an indicator, a key indicator on our SF data website this whole time about PPE. This is really oriented towards healthcare professionals, but I will say, knowing that the supply chain access is challenging, it was really challenging early on, it was a big focus of them to get that equipment, particularly to SNFs, less so to RCFEs. And then all sorts of things come up, like a lot of these places weren't really staffed up or prepared to fit test everybody all of a sudden. So helping them think through things like that. So just, again, practical implications of some of these guidelines and frameworks. Then testing, this has been an absolute cornerstone, obviously related to the asymptomatic nature of infection for many people, and how obviously challenging that is to detect and address if you don't have universal testing. So just to point out that our health order mandated testing since May 7th in SNFs specifically. So baseline testing for everybody, and then regular staff testing at a cadence of once a month in a surveillance mode. The RCFEs have had varying guidance, and theirs mostly coming from their state regulatory agency, suggesting that particularly if they want to open up, have visitors, things like that, they have to do a certain amount of testing among healthcare providers, not totally universal, but a certain percentage. And just to point out that this issue, obviously, in every aspect of society has been a tremendously complicated one, has to do with, okay, well, what kind of tests are we telling them to use? Well, what if that's a huge financial burden? What about the turnaround times? What do we want to say about that? What kind of guidance do we want to give? What is a meaningful turnaround time? So lots of practical advice and issues that come up with testing. And then the goal of the DPH is the second there's a case, we are involved, we are supportive, we are helping, we are managing testing. So response testing, not necessarily if it's just 1 or 2 cases and the facility can manage it, but in outbreak mode, we're all over it. We're the ones managing the testing and organizing that. Of course, the facilities are having to do a ton of work too. And just to point out, very recently, last couple of weeks, the state now has required SNFs to do weekly baseline testing. At the same time, a little before that, CMS also sent out these rapid antigen tests. So the standard test has been the PCR test, and now they've sent out these rapid antigen tests. And CMS sent them out with a certain number of test kits. And now the question is, of course, trying to provide guidance around now which tests, right? We have all these different tests, and before you were saying use only the PCR test, for example. So an example of how guidance can get kind of tricky and change all the time. Then the last thing, an incident command structure. I don't know if you've had experience with an incident command structure. I have sort of loosely understand it now, but people actually do walk around with these vests and these different name tags, and different colors indicate different parts of the response. That is the mode of the command center currently. This is obviously not the COVID command center because there is a really nice table. We were at Moscone with the standard conference tables, and also obviously nobody's wearing masks, and I'm not allowed to take photos in there. But really the goal here is encouraging these facilities to have a good leadership plan and adequate leadership. And I just don't know how realistic that is. I am not saying by any means that leadership at SNFs or assisted livings is bad. I am saying that this is an unprecedented stress and strain, and that it maybe wasn't the perfect fit for every single administrator or leadership team at these facilities. And by no means everywhere, but certainly somewhere, that has been one of the greatest struggles in managing an outbreak or mitigating cases, that leadership is not entirely prepared or trained or ready or capable, or there may not even be enough of them. It may be one administrator in a small place, and it's just an extremely overwhelming task to manage an outbreak. So there's that overall quadruple aim that is sort of a very broad guiding principle to help certainly think through all the major components. But really on a day-to-day, what we're thinking about in outbreak management is all of these modes: prevention, case mitigation, outbreak. Where are our facilities? Where are they at in each of these modes? So they're just going to be very related, but different activities across all of them. And they're all, again, with the goal of supporting infection control, the health of the residents, and the health of the staff, but slightly different activities depending on the mode. And right now, an outbreak is defined as a single case in a resident or more, 3 or more staff who are either a cluster of symptoms, you can start to call that an outbreak, or obviously verified infection. And so prevention, it's all the things you would think about: site visits, educating everybody, training them on PPE, getting them PPE, assisting with an appropriate testing strategy, implementing symptom checks, and at every shift, helping them create mitigation plans. All the SNFs had to actually file a formal mitigation plan with the state. Having them go over staffing plans and giving them resources if they need to staff up, going over the environmental stuff and disinfection, and then controlling to some degree who goes in and out, as that's going to potentially be a mode of transmission. Once there's a case, sort of in mitigation, so not quite outbreak, but there's a case or two, and there you're going to start doing more targeted testing to identify if there's any infection in anybody who might have been exposed. You're going to start to cohort people who you're worried may have been exposed. You're going to go over everything you did before, but you might tell them to increase symptom checks in people just to catch anyone who might have a symptom. And you might be looking a little more carefully at their staffing plans and giving them advice about how to get more staffing should things start to get more hot. And then true outbreak mode, you put on the hood, the bunny suit, you go in there and you roll up your sleeves. And these can be really intense situations with a lot of moving parts, a lot of testing. So the standard mode would be, most often would be twice a week for actually quite some time, several weeks at least, to continue to cohort and move people who are now infectious into a red zone, into a more restricted zone. The state often gets involved particularly if it's a big outbreak and one where there's clearly a lot of transmission within the facility. Even more symptom checks increase, and then you start talking to our colleagues who are working on health systems resources to say, hey, we have a situation, this is a group where a lot of people might get hospitalized really quickly, let's make a plan for that. And then they are required to communicate with our team daily if they're having an outbreak, in order to go over any new cases, any new PUIs, staffing situation, PPE situation, and make sure we're on top of that. So how have we done in terms of outbreaks in the city? So I'm going to show you data from our SNFs. This is called the EPI curve, where by date we look at the number of cases and fatalities. And then I'm going to show you the RCFEs. So for SNFs total, we've had 350 cases so far. You can see we've had a couple of blips where there are bigger outbreaks. The blue is staff cases, the green is resident cases, and the orange is fatalities. So total, we've had 24 fatalities, which is 24% of our city total, and had slightly more cases in residents than staff, but only fatalities in staff at this point. I would have liked to show you hospitalization data. I just wasn't as confident in that data. And all of this essentially is available on our state website, but It's just not broken down like this. Then in our CFEs, we've had about 149 cases to date, with 95 of those being in residents. And unfortunately, in the case of several larger outbreaks at the end of the summer, quite an additional number of deaths. Whereas for a long time, it was just 2 deaths that had happened earlier in the pandemic. And sorry, just to point out, I think you can appreciate that on both levels, there was a much quieter period in the early summer when our community transmission was really low, but things have really picked up again. This isn't really particularly scientific or academic, but just wanted to say, early on, it was clear that a couple places with really seemingly unfettered outbreaks were kind of caught unaware. Again, we weren't really up on our COVID prevention strategies yet. However, now things, we're doing all the contact tracing, hearing what happened, how did, this resident get infected or have symptoms and need to go to the hospital, and just finding that it's the kind of things you would expect. It's the things we know are going to lead to transmission. So staff are bringing after they have done things that put them at higher risk of infection. So not doing social and physical distancing, so carpooling without masks, contact in the break rooms that goes into the high exposure category, get-togethers outside of work. We've had people working with symptoms, which have led to a couple really serious outbreaks. I mean, by serious, I mean a lot of people got sick. And then also clearly asymptomatic infection continues to play a role. So I think that does speak to, well, if now we're going to weekly testing, maybe that will be less of a factor. Okay, well, thank you for coming with me on that review of different elements of the public health response to COVID in these settings. Now, I'll just sort of address briefly what the heck is a geriatrician, or what can other geriatricians do and contribute to this public health response. I really think this has been a unique instance of usefulness on my part, maybe more than usual. I think a lot of people were pulled to help, right? There's no emergency elves that come out of the woods and just know everything about how to address this emergency. These are professionals from all walks of life. We have people who usually work at juvenile hall, do the travel clinic, do flu clinics all over the city, just pediatric care. So people are coming from all over, being put in different roles. And we know these settings so much better. We know the needs of the residents. We know who these residents are in certain ways that these people don't. And I think that advice, experience, expertise has been invaluable as people plan their site visits, the response, what's our approach going to be, things like that. I really think that I have felt disproportionately useful than I normally do in this setting. The other thing is there's clearly some tricky aspects of this, right? A public health approach is going to be blunt in certain ways and population-based, and that does not feel great to the geriatrician clinicians in us. And I think having myself, Louise Aronson, and Meredith help go over certain policies and policy changes has helped to elevate the voice of those residents in these policy considerations. And probably the biggest one was conversations we were able to take part in and give counsel to around loosening restrictions on visitation, because we're the ones reading these stories about the New York Times, about the isolated residents in these facilities and the hug tunnels in Brazil that I wish we had thought of, and I still wish we had. And knowing that there is an approach here that would incorporate the needs of these folks and also continue to keep people safe and adhere to good public health practice. I also just want to say it's been really heartening and cool and inspiring and amazing to see the advocacy that's going on. Many of you, I'm sure, who are listening are probably these advocates and doing advocacy in your area and the things you really care about as it pertains to this response. So Mike, specifically in the area of congregate living and isolation and those issues that are really prominent with this response for these settings, folks like Mike Wasserman, again, Louise Aronson, Charlene Harrington, and Carla and their ground rounds. And then of course, Joanne Lynn, who's an incredible thinker and advocate. And one article that she wrote really continues to stick with me, just about having a pragmatic approach, even as we are shooting for the best public health measures we can possibly obtain to limit the spread of coronavirus in a population where it is clearly hugely mortal and morbid. But the title sort of says it all. We're really got to play the cards we're dealt with. We can't pretend like we're going to prevent COVID. It's going to get in no matter what. And I think that's true. We had the lowest transmission rate of the summer, but that didn't mean we didn't have any cases. It's going to get in. People can't be 100% compliant with everything. And so just taking a pragmatic approach and using that to balance the needs of other voices in the community. And I think we all know, and we've all heard, and I've seen many of you advocate for balanced responses around things like public health measures that reduce the risk of COVID, and potentially more visitation and more activities within those settings to allow for better quality of life. There is nothing that's going to be risk-free. So how do we balance these things? And I think incorporating more residents and families' voices, and us as geriatricians being able to bring that in a measured and thoughtful way to policy discussions and to just on the ground response to these outbreaks and scenarios has been really helpful. And just to point out, I know many of you have seen the advocacy and articles about Dr. Palmer, whom I don't personally know, who's a retired geriatrician and whose mother is now 103 and has been in the paper a lot about advocating for more visitation and how to balance that. So I guess I'll leave you with the usual conundrum for a geriatrician, which is all these things are swirling around. The need to be pragmatic if we know that for a certain population, we're not going to be able to 100% prevent COVID, but we can't ignore the fact that they also have high mortality from other things and they're competing priorities in their lives and they should have to say. The fact that public health measures are really effective and how do we continue to promote those no matter what? How do we continue to allow for human dignity and living life while this pandemic is going on for people who are in these facilities, and thinking about all the resources, all the people that come in contact with these scenarios and this pandemic and all that goes into this as we're sort of sorting this all through. And that's why it's been really fun to be part of the on the ground work that is trying to put all these together in a very practical work a day kind of way. So what's next? I think we know we're going to be living with this for a while. And so I guess all I can really say there is that I really keep several things in mind, which we need the messaging to be, the more we reduce community spread, the less we have to deal with it in congregate settings where it is so challenging. We are so in this together. It is not that just older people will have to be locked away forever, or we're just going to have to accept that they pass away. There is a way to reduce this for everyone, which is to reduce community spread overall. We know that congregate settings are going to be a focus of this no matter what, until this thing is completely gone, because it's just an incredibly high risk scenario. And I really have felt our utility and an appreciation from colleagues for being part of this response. And I'm certainly very grateful for it. And wink, wink, hint, hint, there's plenty of room. So let me know if you have a little extra time. And this has been also a really tremendous journey, and one where I have annoyed many people in asking for help or leeway with other deliverables in what is otherwise a job that I'm having to ignore quite a bit. But really a huge, tremendous thank you to the camaraderie among the other geriatricians in this division and in this institution who are also part of this response, Louise, Meredith, Edgar, and Jeff, and also just the incredible work of everybody I've now gotten to meet and work with in the Department of Public Health and the Command Center. And just to point out, these are 3 of the nurses I work with on our outbreak team. Right now we have 5, and look how good we are about social distancing and masking. She's particularly good. That's Fern, that's Kayleen, that's Robbie. They're all excellent. We have, none of us as of yet have either been the bearer or recipient of COVID. And definitely a huge thanks to you, Louise, and also my many other bosses and colleagues who have let me get away with things in order to help lend some of my time to this effort. And Mike Wasserman and Charlene for their support thinking through this time. So thank you so much. I do see that there are some things in the chat, and I will do my best to try to figure out how to answer those. And also forgive the slightly macabre sign out, but I think it's just to point out, this is the way I think about what's at stake, right? There's lives at stake behind these windows and behind these doors in every possible way. And so just trying to think through that. Okay, I see some wonderful open questions. Okay, yeah. I'll be quiet.
Thank you, Anna, for this tremendous presentation and for your tremendous work in this area. So I will read off some of the questions for you to answer. We do have some great questions here. So the first one I'm going to ask is, the federal stimulus provided a lot of support to hospitals for COVID-19. Did long-term care facilities receive help from that bill? Are advocacy organizations working on including more support if a subsequent stimulus is passed?
Let me unmute myself. Okay, so my understanding is there was actually separate support, and to the tune of almost $10 billion, I thought that was supposed to at least either be entirely for SNFs, which seems like a lot now that I'm saying it out loud, or at least in part. I haven't heard anybody talk about getting it. There was certainly some incentive at one point for assisted living facilities from the state to the RCFEs to take COVID positive folks and care for those folks, and do so with additional funding, meaning hopefully they would have the required PPE and staff. But I don't know, and I'm very curious, because the overall story on that side of things has been that these SNFs are really hurting, and many are closing. Certainly RCFEs have closed in the city. And we hear all the time about the burden of the cost of testing, not taking admissions, all of those things. So I do really wonder about why I hear what you heard, which is that there is stimulus money, but they are also saying that they are not financially viable in many ways. So I'm sorry, that's not a great answer. I should learn more, but theoretically, yes, they should be able to get some of that money.
Oh, that's great. And here's another easy question for you. It's been suggested that frail elderly should be high priority for the early use of a COVID vaccine, just behind essential health workers. Some has disputed this, whether it's a good use of the scarce resource, and whether you have an opinion on this issue, and whether the lessened immune response might mean frail elders would not benefit as much from a vaccine. Thoughts on targeting vaccines to skilled nursing home or RCFE residents?
I think, however you would think to deploy a preventive intervention like that, this is clearly the population that's highest risk mortality. So I would think it would be incredibly valuable to give to those residents. I think that would also allow, obviously, for less restriction on who can go in and out of the facility if they're the ones who are protected. Instead of, let's say you took the approach of only vaccinating their care providers, then you would have to still restrict their access to only those care providers. So I think, actually, I don't particularly know clinically how the vaccine is going to work or in terms of efficacy. Obviously, I think we're all concerned that those folks are not being included in certain trials. I will say, though, one thing I've been wondering about more generally as well is just simply if the death rate or the death and mortality from among those who are COVID infected and residents in skilled nursing, if that is going down, because we do know that we have treatments that are clearly reducing the mortality and are now fairly universal.
Great. And one person asked, you talked a lot about nursing ratios. What about the providers that come into nursing homes and risk factor? Is the number of providers that are providing care at any one facility, is that been a risk factor for increased COVID cases?
Awesome question. I'm not sure. I think what we do know is that the larger the facility, certainly the higher risk overall. So you have to imagine that more people really means, a larger facility really means more staff. So it's possible that there's an increased risk, but overall thinking there should be a modifiable feature there, which is that those folks are trained and have access to adequate PPE, which would presumably allow for better care and ultimately less risk of coronavirus. I don't know if that makes sense. Kind of in thinking, if you have more nurses, you have less coronavirus as well, because presumably the better care is an aspect of that.
Great. And how realistic is it to have a full-time infectionist for every facility? What about facilities with less than 150 residents who are often struggling to maintain full-time 24/7 RNs? Where is the workforce? Would that require, such a mandate cause smaller nursing homes to close? So what are your thoughts on that?
I think it's the proof is in the pudding. I haven't seen a full-time infection preventionist at any of these facilities except the truly massive ones. So Laguna has, like I said, over 700 people. Jewish Home has over 300 residents, right? Almost 400 residents. And those sorts of places can have, and maybe they sort of can justify all that work. But most places, I have not seen them staff up to that level. So I'm guessing it's not feasible. And in fact, a very common complaint is as soon as there's a really serious outbreak and you're having to really restrict movement and have more staff dedicated to certain areas, that requires them really on a practical level to increase staffing ratios. And you almost universally push back on that. So I think it is a huge issue. And they also have often reported that they can't get the staff. So maybe they do have the funding, but they can't find staff to hire to come.
Yeah.
So I agree, it's a huge issue.
Yep. And then how do we go about changing the visitation policies? So we see all these people with the window in between. What might be things we could do about that?
Definitely key question. I think there's lots of things to consider, but no doubt you could, one certainly practical answer, if it were possible people had universal access, would just be make sure everybody had a very recent test. That would really help. And then PPE, I think making sure that people have PPE, that they're observed putting on the PPE, that they know how to use the PPE, that it's the right PPE, and potentially limiting visitation time. But all of those things really should make it safe. And I think that is something that is clearly coming down the pike and should, has to be part of the future because we are going to be living with this for a while. And so visitation really has to be part of that.
Yeah, I agree. And this will be the final question is the particular challenges of COVID-related infection control for people living with dementia in congregate living facilities. Are there strategies you've seen to really successfully overcome some of these challenges for folks with dementia?
The first, yes, hugely challenging. The first is obviously you can only swim upstream for so long. If somebody's not going to wear a mask, they're not going to wear a mask. That's just reality. You accept it. For places that are units that are really focused on people who have a cognitive disability and aren't going to be able to take other certain measures like distancing or masking or frequent hand hygiene, having the staff trained to prompt them to do certain things like wash their hands more frequently or use sanitizer, but also having that unit have a cohorted staff. So doing everything you can to, in some sense, wall off that area from other parts of a assisted living facility or a skilled nursing facility and not have them intermix. So at the very least, if there were an outbreak, you could contain it. Of course, there have been outbreaks in areas with a high proportion of folks with dementia. And for those, again, you have to think really carefully about who's with who. So maybe cohorting people who are positive and with staff who have already been positive, or the ones who feel more confident about their use of PPE, things like that. And then creating creative environmental barriers to keep movement. So we've seen people use screens to cover up areas that they would otherwise walk through to get to another part of the unit, or put up plastic sheeting. But it can be really, really challenging. And then increasing staff support and ratios for those people to help with redirection and behavioral issues and not turn to things like antipsychotics or other sedative measures to manage behavioral issues as they come up as you're trying to manage the outbreak. But really trying so hard not to get it in that area. And then when it happens, being really thoughtful and creative about cohorting. That often takes a ton of direct support for the facility to help them think that through, and sometimes and often site visits to do walkthroughs around what are we doing here with the barriers, what are we doing with who's in what room, how are you going to clean this bathroom? I mean, everything down to the nitty gritty. So it's a lot of work.
Thank you so much, Anna. Yep, and there are a ton of questions. So if we aren't able to get to all of them because of the time, please email Anna. I'm sure she'd be happy to answer any other questions. But thank you again, Anna. This was tremendous. And thank everybody for attending.
Thanks everybody for the wonderful questions. Thank you.
Great. Thanks everybody.